So first of all, thanks so much for the opportunity to share with all of you our experience in the management of patients affected by deep endometriosis lesions. So the correct management in reference center is starting from correct anamnesis and clinical evaluation. Then is very important the skilled imaging in order to put the correct indication for clinical management, so medical or surgery treatment, and then a complete counseling and informed consent with the patients. And then in case of surgery, surgical experience is mandatory and knowledge of anatomy and the management of postoperative complications. So our preoperative workup in our center, starting from ultrasound, and we use cystoscopy in case of bladder involvement, urography and renal scintigraphy in case of upper urinary tract damage, and a urinary test for lower urinary tract dysfunction with involvement of neural plexus. So we never perform colonoscopy or double contrast enema in case of bowel involvement. The patients with deep endometriosis lesions are treated with medical treatment, but if the medical treatment is not effective or not tolerated by the patients or contraindicated, or in case of bowel stenosis, urethral stenosis, kidney loss function, or infertility with no compliance for IVF, or infertility after 2 or more IVF failure, in this case, we have to perform the surgical treatment. So the key question in diagnostic workup is based on the concept to speak the same language between the sonographer and the surgeons.
In order to address this issue, to share a common language between a sonographer, radiologist, and surgeons, two different mapping and classification systems were recently provided. The first one is the revised NCS score, and second one is the AGL 2021 staging system, and both are very useful tool in order to that can be used both by ultrasound and MRI in order to assess the pelvic and abdominal extension of the disease. So we were very proud to be part of both projects, and what more recently we were also involved in this crucial opinion paper that was an inter-society consensus that assessed the prominent role of imaging in diagnosis deep infiltrating endometriosis, and more in general pelvic endometriosis. So we came to the point in which we can assess that imaging, so both ultrasonography and MRI, that in expert hands show the same or almost the same diagnostic accuracy, can be considered the gold standard for the diagnosis of the disease. Concerning deep infiltrating endometriosis, we should start from the issue that is associated to ovarian lesion up to 80% of cases. So anytime we face a patient with a diagnosis of suspicion of endometriosis, we should always perform a complete assessment of the abdomen and the pelvis. According to this expert consensus, we should provide information about the absence or presence of deep infiltrating lesion in all that pelvic anterior, posterolateral, and the posterior compartment. Of course, adding information about extrapelvic location. Once the lesion is identified, information about the diameters of the lesion should be provided, also according, of course, to the IDEA consensus statement. Diagnosis, ultrasonographic diagnosis of deep infiltrating lesions is not so hard, it's not so complex. Literature data suggests that an average of 30 cases ranging from 20 to almost more than 40 according different location could be enough in order to start to to recognize a deep infiltrating lesion. Of course, probably in the future, artificial intelligence would be of some help in order to identify and teach how to identify deep infiltrating lesion. But the key of a correct diagnosis of deep infiltrating endometriosis is knowledge of the disease and knowledge of anatomy. This is the only way in order to truly share a common language between sonographer, radiologists, and surgeons. A systematic stepwise approach to explore the different compartments of the pelvis is advisable in order to achieve a complete evaluation of the disease, and it should be usually performed with endocavitary approach, so transvaginal, of course, and or transrectal when transvaginal route is not feasible, and it should be always completed with a transabdominal evaluation in order to assess diaphragm, kidneys, and upper bowel segment together with the abdominal wall. Concerning the so-called sliding sign, it's a very easy maneuver that can be performed with any kind of ultrasonographic machine. When we have a negative sliding sign, here we are on the posterior compartment with the bowel that is completely attached to the posterior wall of the uterus. It means that we have severe adhesions, and the predictive value for the presence of deep infiltrating endometriosis is more than 90%. But it doesn't mean that we have deep infiltrating endometriosis. As you can see, we can have also deep infiltrating lesion. Here we have a typical lesion in the bowel, and here we have a typical lesion at the level of the retrocervical area with a completely free Douglas patch in both cases. We can, of course, assess also vaginal and rectovaginal deep endometriotic lesion that can be easily identified with also with pelvic manual examination. But of course, imaging can give us more and more information about the extent of the disease. By ultrasound, we can observe, not with it's preferable with a linear probe, also the abdominal wall in order to identify lesion in atypical sites and together with diaphragm. But for sure, the area in which the role of imaging is absolutely mandatory in order to assess a proper surgical strategy are bladder, retrocervical area, parametrial area, and the bowel. Concerning bladder, it should be observed not completely empty. The different compartment of the bladder should be noted. The presence or absence of a cleavage plane with the anterior wall of the uterus. Urethra, ureteral meatus, and the intramural segment should be assessed at any time, because when we identify deep infiltrating lesion of the bowel that in more than 90% of cases are located at the level of the base, we should give information about the 3 orthogonal diameters. Of course, the muscularis involvement, even because lesions that are limited to the serosa are considered superficial endometriosis. The distance, anytime the distance from urethral and ureteral meatus and intramural segment should be assessed, and of course, the presence or absence of a cleavage plane with the anterior uterine wall. Ultrasonography can be also useful in order to make a differential diagnosis with bladder neoplasms, in which vascularity is completely different. It's clearly higher, but almost most of all, in these cases, the inner layer of the bladder wall are involved more than the muscularis.
So for the surgeon, all this information are mandatory, so we can plan more correct our surgical strategy. In this case, we know from the preoperative ultrasound evaluation that the infiltration of the bladder wall is only at the level of the serosa and at the level of the muscularis. There is no infiltration inside the mucosa, so the mucosa is totally free, and so we know before surgery that we can perform this kind of shaving technique on the bladder wall. In this other case, the infiltration is deep inside the lumen of the bladder, but we know from the preoperative ultrasound that the size of the nodule is very small, and so we can perform this easy surgery, and we can talk to the patients that we never need to put the stents inside before or after surgery, and we can talk with the patients about the technical reconstruction. That is a simple reconstruction of the bladder with a very low risk of recurrence and very low risk of complication. But if we have this kind of infiltration at the level of the trigonum, and we know from the ultrasound that the lateral limits on the left side of the bladder nodule is very close to the intramural tract of the ureter on the left side, we can talk with the patients before the surgeon and speak about the high risk of left side urethral resection, high risk of postoperative stenosis, and the risk of recurrence. So it's a totally different surgery with the risk of complication absolutely higher than compared with the other cases.
Concerning the retrocervical and the parametral area, according to literature, accuracy of ultrasonography was not very high, but probably it was just a matter of absence of a common definition criteria. Recently, we published this paper in which we considered the uterosacral ligament as an anatomic landmark. Uterosacral ligament is clearly visible by ultrasound as this hyperechoic band of tissue running from the retrocervical border of the cervix through pararectal spaces up to the pelvic side wall. And when it's affected by deep infiltrating endometriosis, we can clearly see this typical solid hypoechoic lesion disrupting the anatomy of the ligament. The uterosacral ligament can be considered as a landmark in order to assess lesions that extend beyond the lateral limit of the uterosacral ligament or along the uterosacral ligament in the dorsal compartment. So it's crucial in order to define the presence of deep infiltrating endometriosis affecting the parameter. And using by this kind of criteria, we reached very high sensitivity and specificity in identify this kind of lesion. Of course, it's less likely that the anterior parameter can be affected, but it should be, of course, always assessed. But most of all, the area in which more often we can find deep infiltrating lesion are lateral and dorsal parameter. And it's very important to assess those compartments because ureters and nerves can be affected. In case of a lateral deep infiltrating lesion, we should observe the relationship between the lesion and the ureter. We can measure the distance between the lateral margins of the lesion to the ureter, observe when they are completely in touch or when the ureter is completely enveloped by the lesion. And of course, in those cases, it's more likely to have a compromission, functional compromission of the urinary tract. Concerning dorsal lesion, those are the ones in which the more probably that the pelvic nerve plexa can be involved. So it's an important information to provide to surgeons before the procedure, also in order to counsel patients about the risk. More recently, the concept of the parameter was added to the IDEA consensus, because in its original version in 2016 it wasn't included.
So in case of parametrial involvement, this is a video where we perform a parametrectomy on the left side. So we injected the indocyanine green in order to identify better the left ureter. This is a technique when we go to remove completely the parametrial area with the previous partial parametrectomy on the same patients. In case of total infiltration of the ureter, we have to perform a resection with end-to-end reanastomosis. And in case of infiltration and stenosis of the ureter very close to the intramural tract of the ureter in the bladder, we have to perform the resection and the reimplantation. This is the new technique that we use to perform inside the broad ligament the anastomosis in order to cover at the end the peritoneum, in order to have have a good distance with less risk of adhesions between the area of anastomosis and the left ovary and the left tube. And sometimes you have to perform an hysterectomy with the parametrectomy, with the ureterectomy and nephrectomy at the same time in order to remove completely all the lesions and the kidney with the totally loss of function of the ureter. And you can see at the end, after the extraction through the vagina, the rest and the specimen like in the picture.
Concerning the bowel, this is the area that we can cover by ultrasound, in which the majority of bowel nodules lie. So it's also the reason why we usually don't ask for MRI. This is the typical bowel lesion affecting the muscularis. That is this hypoechoic layer of the wall. Of course, bowel lesion can affect also the inner layer of the bowel wall, but it's really unlikely, and this is also the reason why colonoscopy should not be required in order to assess bowel infiltration by endometriosis. Let me show you how to properly measure the deep infiltrating nodule. We can assess the anteroposterior diameter. We mean the depth of infiltration at the level of the muscularis, the length of the lesion with a curved line following the bowel wall in order to avoid to underestimate the nodule. In a transversal section, we can assess the transversal diameter of the bowel, and also, of course, we can assess the percentage of the involved circumference. We can observe this difference in terms of echogenicity when we have also component of superficial disease at the level of the serosa. And another information that we can give the surgeon is the distance from the lower margin of the nodule to the anal verge. A few years ago, we published this paper in which we compared the diameters of the nodule measured by ultrasound with the fresh specimen, finding a complete correspondence. I go fast in order to show you how we can make a differential diagnosis with the bowel neoplasm, in which the muscularis is almost completely normal, and the vascularity you see is very high compared to the typical deep infiltrating lesion. Of course, by ultrasound, we can, combining transvaginal and transabdominal approach, we can assess also the right iliac fossa, identifying small bowel lesion, appendiceal lesion, and involvement of the right colon and the cecum, obtaining with those criteria very high sensitivity and specificity on all these segments.
So the decision-making process should take in consideration the size of the nodule, the depth of infiltration, the number of the lesion, the circumferential bowel involvement, the distance from anal verge, and percentage of stenosis. So this is very important. Our cutoff is 7 millimeters of infiltration of muscularis. So we can do a conservative treatment, a shaving in all cases with infiltration less than 7 millimeters. If the infiltration is more than 7, but the cranial size is less than 3 centimeters, we perform a discoid resection, and we perform a segmental resection only in case of nodule bigger than 3 centimeters and deeper than 7 millimeters. This makes the difference because we know all this information from ultrasound, and we can plan our surgery in order to reduce the percentage of segmental resection, increase the shaving technique, increase the discoid resection, because sometimes we can do a shaving on the superficial part and then a discoid resection. This is the technique of shaving technique. Then we published our technique for discoid and double discoid technique, and we know everybody know the technique of discoid resection. And then we moved from the segmental resection with the classical technique to the modified nose technique with the natural orifice specimen extraction, using the access of the rectum in order to remove the segment resected and in order to introduce the spike and perform the end-to-end anastomosis. So we use the rectum to extraction and to go inside with the anvil and the spike, and then we perform the final part of the surgery. We published our trend. It's surgical treatment women with deep endometriosis infiltrated the sigmoid and colon using this technique with very good results in terms of percentage, no intraoperative and postoperative, no intraoperative complication, no protective stoma, only 3.7% of grade 3 complication with the 1 hemiperitoneus, 1 urethral lesions regarding the parametrectomy, and 1 rectal bleeding. And so the surgical outcomes was very good, only 3 days of average of hospital stay. And so we can do in conclusion, we can say in conclusion that starting from skilled imaging with skilled ultrasound, we can have a good management of patients from medical to surgical treatment, and then we can tailor our surgery in any case with the centralization of patients in the reference centers. So thank you so much for your attention.
From both of us.
From both of us. Thank you so much.
Bye.
Bye-bye.